Thank you very much, Dr. Hazza, for your nice presentation. Our next speaker for tonight is Dr. Muhammad Sharif. He is a consultant internist with interest in venous thromboembolism at King Fahd Medical City in Riyadh. He will talk about special issues, COVID-19 infection and thrombosis. Dr. Muhammad, you can unmute yourself. Unmute yourself.
Okay. Thank you for the introduction. If you allow me to share screen.
Okay.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, ladies and gentlemen. It's really my pleasure and honor to present about this topic, thrombosis and coagulopathy in COVID-19 patient. Really, I would like to start my presentation by thanking the Saudi Society for Blood Disorder for this informative symposium about cancer-associated thrombosis. Although the theme is about cancer-associated thrombosis, but we are just discussing very hot topic about COVID-19 infection and thrombosis. It is emerging hypercoagulable disease. Would like to start first, just show this slide about the COVID-19 data tsunami. Really, we have a tsunami of data of COVID-19. And physicians are drowning in COVID-19 paper, about 23,000 papers and doubling every 20 days. It's very difficult to catch up about all, updates of COVID-19. And start by highlighting my learning objectives. After attending this webinar, participant will be able to review the cross-link between thrombosis and inflammation, discuss the common coagulopathic abnormalities in COVID-19, and provide some practical guidance for prevention of thrombosis and management of coagulopathy in COVID-19, mainly ISTH and chest guideline, and recently published American Society of Hematology. Also to integrate the latest evidence about thrombosis and COVID-19 into clinical practice, which is the most important, and to briefly how manage effectively and virtually anticoagulation and thrombosis in COVID-19 era, and when to request diagnostic imaging for COVID-19 with suspected VTE. I will start to put you in perspective by two dramatic case presentation whom I managed in the inpatient covering COVID-19 team. A 45-year-old female with no chronic illness, previously healthy. She was brought to the hospital after a transient loss of consciousness at home, followed a 2-week history of dry cough and shortness of breath and 3-day history of palpitation. She was found to have right-sided weakness, typical, stroke symptoms. She was desatting and hypotensive. Her NIH score was 21, indicating very severe stroke. So she was diagnosed with a massive PE, acute stroke, large vessel stroke, splenic and renal infarctions. Her SARS coronavirus 2 PCR screen came back positive about 3 days after hospitalization. So this patient, her initial laboratory parameter, she has leukocytosis and she has neutrophil to lymphocyte ratio is decreased, platelet count is normal, troponin was high, probin B was high, lactate was high, D-dimer was very high, LDH was high, and ferritin, this is the initial result, but later on, the second day, it was tripled and increased. So all inflammatory markers were elevated in this patient. So this is the CTPA showed bilateral massive PE, sudden pulmonary embolism. This patient have very resistant hypotension. We could not thrombolize this patient with a systemic or catheter-directed thrombolysis due to the presence of bilateral large vessel stroke with hemorrhagic transformation. So this patient, very, a dramatic presentation. Remember that COVID-19 is a great mimicker of multiple diseases. And from this, we think that any patient presenting with a vascular presentation, whether VTE or stroke, I think COVID-19 status should be checked. This is another patient. This is about 2 weeks ago. Young, he's middle-aged patient without any chronic illness. Also presented with unprovoked massive DVT with a limb venous threatening gangrene. So phlegmasia, cerulodolens, and ER physician consulted vascular surgery as acute ischemic limb. Then they requested Doppler, and they found it is extensive iliofemoral thrombosis up to the external iliac, and CT was done, CT angio, and showed a picture that similar or compatible with May-Thurner syndrome, i.e. right iliac artery crossing the left iliac vein. COVID screen came back positive. This patient, actually, he's presented in very advanced stage. I think this is, related to patient reluctance to seek medical advice and fear from exposure of COVID-19 from the emergency. That's why they present late with catastrophic presentation, like I see in the first patient and the second patient. So this patient underwent IV filter insertion and catheter-directed thrombolysis. It was pharmacomechanical through angiojet technique, and because they diagnosed him to have May-Thurner syndrome. So this patient, he's 58. Why he developed DVT right now? I think this is multifactorial. The COVID-19 coagulopathy, in addition to the mechanical factor May-Thurner syndrome. So this is another case. So this is post-catheter-directed, thrombolysis or pharmacomechanical, significant improvement. So the limb back to the normal color, also the size regressed significantly, and there is hematuria because the hemoglobinuria due to the fragmentation of the thrombus. Another patient, this is just, it's very, disease, it has, I will say, heterogeneous presentation. So like young patient, they die from massive PE. On the other hand, we have seen elderly patients, super centurion Saudi female who recovered from COVID-19. So the picture is heterogeneous. We don't know exactly, we cannot pinpoint. We say this patient is gonna, die, or this patient will be complicated course. Nobody knows. It depends on the immune system, host immune response. And I will show you in the subsequent slides about the link between thrombosis and inflammation. So this is our, status in Saudi Arabia. So we have, this is the most recent update today. We have 258,000 and recovery, mashallah, 210,000. And the recovery rate reached to 80%, and mortality rate about 1%, which is 10 times less than international, figures. And globally, we reached to 15 million. So interestingly, the etiology of this virus, all we know it is severe acute respiratory syndrome coronavirus 2. It is RNA virus that belongs to the beta coronavirus. Very interesting, it is homologous, the SARS coronavirus that, caused the epidemic 2004. It also the SARS coronavirus, one associated with large vessel stroke and increased risk of vascular thrombosis. So that's why they are really, identical to each other. So where do we stand with COVID-19? The pathogenesis that I shed light more in it. It is, so we know the virus uses ACE2 as a receptor, ACE2 receptor, very rich in the respiratory tract. They bind to spike to glycoprotein on viral envelope. In response to viral antigen, we have immune cells release pro-inflammatory cytokines and chemokines, result in uncontrolled systemic inflammatory response. A picture that mimic cytokine storm syndrome, or LHH, or the other name for it, macrophage activation syndrome, and hemophagocytic syndrome. So the incubation is and contagious period variable. I will not just discuss it. Just the clinical presentation. Yes, yet the most common clinical presentation is respiratory fever, dry cough, malaise, myalgia, headache, and dyspnea. But this disease can present with polyvascular disease. It can present with a VTE, DVTP. It can present with stroke, with acute MI. It can present with microvascular thrombosis. So it can have. Also, very interesting about this virus is like a presentation, a weird presentation, loss of smell, loss of taste. So this is really, treatment for this virus. We don't have specific or target treatment. We have what we call open buffet approach. So this is the only, I would say viral infection that we use. Imagine we are using all these supportive therapy, oxygen, vitamin D, vitamin C, zinc, antibiotics, steroid, dexamethasone, and methylprednisone, hydroxychloroquine, antiviral, favipiravir, and remdesivir, interferon beta, tocilizumab as interleukin-6 pathway inhibitor, convalescent plasma, which is very promising, and anticoagulation. So we are using, shotgun approach, to fight, to combat this disease. So I will focus about the anticoagulation, which is, the theme of my presentation. So just to know that COVID-19 is hypercoagulable state. The natural history is different than the usual venous thromboembolism we know. So the usual VT, we know that DVT form in the leg distal, distal DVT below the knee, and usually distal have 25% embolization to the lung, and if it is proximal, the risk of embolization about 50% in spite of absence of chest symptoms, and it can have multiple showering of emboli, or they can have massive pulmonary embolism. We think this is in COVID-19, this is different. It is pulmonary thrombosis, pulmonary artery thrombosis rather than pulmonary embolism. So it is de novo pulmonary embolism, or in situ pulmonary artery thrombosis, because this is observation was found in other studies, and they we call it like immunopulmonary thrombosis. Yes, they have DVT, but most common they have pulmonary embolism, and they can have presentation with microvascular thrombosis in the skin, like this is a purpura crash, this is livido reticularis. This is a stroke, so they can present acute MI. So different presentation, and really have, wide spectrum of vascular presentation. And this is very nice, scheme to show you that it can cause arterial thrombosis. So stroke, also acute MI. Our colleague in cardiology, they noticed many patients they have acute. I'm covering currently COVID-19. Many patients like transferred from. I'm covering non-COVID team. So many patients transferred from COVID team to non-COVID after, recovery, but still they have acute coronary syndrome. So acute coronary syndrome is one of the manifestations of COVID-19. Also, they can have PE, DVT can have microvascular thrombosis and endothelial damage. So they have different, wide spectrum of vascular presentation. So I call it polyvascular disease. So the pulmonary thrombosis and COVID-19, so they have we think it's not like systemic DIC, they call it local DIC in the lung, pulmonary DIC, pulmonary vascular thrombosis with subsequent activation of, fibrinolysis, vascular microthrombosis. So the concept of pulmonary thrombosis has been recently proposed for condition other than, COVID-19, like pneumonia, asthma, chronic obstructive pulmonary disease. We think these patients, they present with PE more than, DVT. That's why we call it, pulmonary thrombosis. So the development of DIC, local DIC, is due to activation of cytokine-producing monocytes, such as interleukin-6, tumor necrosis factor, which in turn induce activation of endothelial cells and tissue factor that triggers the blood coagulation cascade. So they would have what we call endotheliitis, and leakage of the capillaries that lead to ARDS. So this activation of blood coagulation, this is essential in counteracting viral infection along with immune system. So this is beneficial, to fibrin, production to trap viruses by fibrin network, thus limiting their dissemination. However, what will happen, this is like over, reaction or massive inflammatory and coagulative response is dangerous because it can lead to thrombosis in the lungs, like what we call immune dysregulation in this case. So, there is pulmonary immunothrombosis and COVID-19 infection. So what will happen, this is post-mortem finding showing microthrombosis, or this is fibrin necrosis. So you have the cytokine storm that lead to endothelial activation, also platelet activation, leading to tissue factor activation pathway, leading to the fibrin formation and thrombosis, and downregulation of thrombomodulin, because this is natural anticoagulant. In addition, this is about pulmonary postmortem finding, a series of COVID-19 cases from northern Italy, and showed this is microvascular thrombosis. This is from the lung. And what the cross-link between hemostasis and inflammation, we know that this is inflammation leading to activation of the coagulation cascade, leading to conversion of fibrinogen to fibrin, and we have fibrin clot lysis leading to the what we call D-dimer production. So we have activation of coagulation and fibrinolysis pathway. So there is a cross-link between thrombosis and inflammation. This is what will happen if you have, like many other infection, but we think COVID-19, it is more intense, different than other. And I will show you the risk between hospital-acquired thrombosis from pneumonia versus COVID-19. This is different than other viruses. There's a significant cross-link between inflammation and coagulation. We know about it. COVID-19 stimulate the endothelium, activation of the endothelium, activation of the mononuclear cells and neutrophil monocytes that lead to the production of pro-inflammatory cytokines and chemokines that activate the tissue factor mediated coagulation activation and leading to fibrin formation. And these, the fibrin formation also activate inflammatory cells that produce inflammatory cytokines. There is a vicious cycle leading to the activation of coagulation and inhibition of fibrinolysis, and there is impairment of natural anticoagulants. So severe COVID-19 generate an increase in pro-inflammatory cytokines and activation of endothelial cells, endotheliitis, neutrophils, monocytes, and platelet, leading to tissue factor-mediated activation of coagulation. And also the inflammatory response to COVID-19 result in activation of coagulation that itself may modulate further inflammatory activity. This is just to show you the similar to the previous, diagram or cartoon. So in response to COVID-19 infection, you have endothelial activation, also activation of the monocytes that they secrete the pro-inflammatory cytokines from the endothelium and
3 minutes. 3 minutes.
Leading to the formation of clot. So D-dimer is a fibrin degradation product. Why are D-dimer levels increase in COVID-19? We think this is as a result of the systemic thrombin generation and subsequent fibrin formation. So we know that D-dimer is a marker of coagulation and fibrinolysis activation, but in COVID-19 used as a biomarker for disease severity and mortality in these patients. So we know D-dimer is elevated in many conditions, and now COVID-19 infection, so we cannot rely on D-dimer to roll in or roll out VTE, because this is non-specific marker. It has only excellent negative predictive value. So we know the incidence of VTE in COVID-19 patient, it's high incidence, and we know it is more in ICU or critical ill patient than ward. And there are many, reports, case studies, case series showing that high incidence of venous thromboembolism. And we know that undiagnosed pulmonary embolism could contribute to sudden and unexplained respiratory deterioration and sudden death. So very high D-dimer point to, I think it is high risk for venous thromboembolism in the patient, and also a marker of severity of inflammatory pulmonary disease. So this is, to show you this one, this is high incidence of COVID-19, high incidence of VTE in COVID-19 patient compared to influenza. So this is about 485 patient COVID-19. They found a 30-day incidence of VT about 3.8. This is the general ward, and in ICU patient is 15%. If you combine together, gonna be 18.7. Some other report the incidence about 30% in critical ill patient, but however, influenza patient 1.04. So this is really disease. I mean, incidence of thrombotic complication, hospitalized COVID-19 patient is very substantial and considerably high than in hospitalized influenza patient. Also, D-dimer, just be aware it is elevated in not only in COVID-19, also in non-COVID-19 patient pneumonia. So you can see this is 1.94. Almost they are, comparable to each other. Another important incidence of thrombotic complication, critically ill patient, it's high, about 31%, including arterial and venous thromboembolism, in spite on standard or routine VT prophylaxis adjusted to weight. So this indicates that we should use higher dose or intensify prophylaxis to intermediate or therapeutic anticoagulation. We know patients who are, non-survival of, COVID-19, they have the D-dimer is very high, about 81% compared to survival about 24%. We know D-dimer more than one help a clinician to identify patient with poor prognosis. This is more similar. The most important is that this is a dynamic disease. So we know there is markedly increasing D-dimer level over time. So not only we rely on it upon admission. See this is the initial presentation, and see this is patient, non-survival. It is rising with time. So 3 to 4 fold over time, indicator of poor, poor outcome and increased mortality. Just to low molecular heparin was associated with decreased mortality, especially in patients with D-dimer more than 6 upper limit of normal, i.e. more than 3, and patients who have sepsis-induced coagulopathy. Many patients, they are found to have lupus anticoagulant is positive, although we know that lupus anticoagulant is transiently elevated in patients with infection. This is a case, 3 patients presented, published in New England. They have stroke and antiphospholipid antibodies, but none of them have, they did not report lupus anticoagulant, only anticardiolipin and anti-beta-glucan. This is very important. Post-discharge, these patients.
1 minute, please.
I will just go to the conclusion of my presentation. This is the most reliable guideline, ISTH guideline. They recommend to start to give routine standard VT prophylaxis for ward and ICU patient until the available evidence from randomized controlled trial for using therapeutic anticoagulation and diagnosis. We should not rely on D-dimer to request for diagnostic testing. It has to be clinical, in addition to respiratory status if the patient deteriorating in spite of borderline or just abnormal X-ray. So you need to proceed to just guidelines, standard prophylaxis. Just to go to, this is the most recently European Society of Cardiology. They recommend intensification of thromboprophylaxis to therapeutic dose if the patient admitted to ICU. So summary and key learning point. So the lab characteristics of severe COVID-19 infection are, they have a mildly to moderately reduced platelet count, usually normal count in the most severe patient. And if you have it low, like in patient last week, you have to suspect like hit, like our patient came to be hit. They have mild prolongation of the prothrombin time in minority of patient. They have high fibrinogen level in virtually all patients with very low levels. If the patient briefly before death, they develop DIC. and very elevated D-dimer level, in particular non-survival, and they have normal natural anticoagulant. So the most common pattern of coagulopathy observed in patients hospitalized with COVID-19 is elevation in fibrinogen D-dimer, and this correlates well with parallel rise in marker inflammation like CRP, ferritin, LDH. Unlike the pattern seen in classic DIC, so usually they have mild thrombocytopenia. Some patients with severe COVID infection can develop a coagulopathy meeting DIC, and they have, full-blown DIC, ICH DIC criteria. So this is the last slide. Elevated D-dimer at admission and markedly increasing. D-dimer level 3 to 4-fold over time were associated with high mortality. This is likely reflecting coagulation activation from infection, sepsis, cytokine storm, and impending organ failure. Therapeutic anticoagulation is required for VTE treatment and high-risk ICU patient, and the efficacy of intermediate or full therapeutic anticoagulation for critically ill COVID-19 patient without documented VTE is under study. So this is rapid coag study in Saudi Arabia. We are participating in this study. And in patients already on anticoagulation for VTE, usually like on DUAC, during hospitalization, we should switch to low heparin because the significant interaction with antiviral therapy, and prophylactic dose low heparin is recommended for all hospitalized patients. So this is now all hospitalized patients with COVID, they should receive standard routine VTE prophylaxis. If there is contraindication, you should use mechanical prophylaxis. To conclude, by a few words of gratitude for all healthcare workers, our resident, ER, ICU, really close contact with these patients and frontline treating COVID-19 patient. You are really indeed super heroes. Thank you very much.
Thank you very much, Dr. Muhammad, for this nice presentation. I would like all the speakers to unmute yourself so we can have some questions. And please just be concise in answering because you have a lot of questions and very limited time.